Hello and good morning. Today's topic is access to care. My name is Arindam Basu and I am an associate professor at the School of Health Sciences. You can contact me at arindambasu.basu@canterbury.ac.nz for any questions and comments that you may have about this presentation. So let's get started. In this presentation, we are going to cover firstly, how we can judge or how we can evaluate the performance of a health system. And then I'm going to talk about what do we mean by access to care. So define access to care. And then I'm going to talk about the different types of access to care in any health systems. And then I'm going to talk about two theories of accessing care or accessing healthcare. The first theory is the theory of using Anderson-Gelberg model, also called Anderson model. And the second one is called the 5A dimensions of access to care. It's also called 5A model. So we're going to talk about those two models. And then I'm going to show you some data which will show how access to healthcare is, what is the current state of access to healthcare for a select group of people in healthcare. These are very preliminary data sets, but that'll give you enough talking points for working with these data sets and understanding the state of healthcare access in New Zealand. So let's get started on the first one. How do we assess or evaluate the performance of a health system? Because access to care is integral to that. Now, when we assess health system performance, we look into three things. We consider the cost that is incurred to the health system managers as well as people who are going to use them. So cost in terms of both time and money. We talk in terms of the quality of the services that people receive and the quality of the services that are ensured. And cost and quality are intricately connected to the access to care that is important. So this is why when we talk about access to care, we must always keep in mind the entirety of the health system performance. So cost, quality, and access are intricately connected to each other. Now, there are different types of cost of care. So for the cost of care basically are measured in terms of both time and money. So when we talk about cost of care in terms of time, we talk about waiting time, for example, for a patient. So if you are going to go and see your doctor, how long do you have to wait till you get to see your doctor? If there is a very long waiting time, then the cost of care goes up. How much time does it take to reach the care process? The longer the time, the more expensive it becomes in terms of delivering care, because fewer and fewer people will be able to access or can be seen in that time. And so we calculate the total time that takes, waiting time for surgery, time for rehabilitation, for example, time for chemotherapy, for follow-ups. So time is a very important dimension when we understand the cost of care, and this has got its own bearings on how do we assess access to care. Then there is cost that is measured in terms of money. So how expensive is the care? Think about if you're going to go and say, for example, seek dental care. Dental care is quite expensive in New Zealand. So who is going to pay for such care? So how expensive is the care? Who is going to fund that care? In a system where the government decides to fund care, then it makes it a little bit easy in terms of care on the individual, but total cost of care will still remain quite high. So all of these things come under the consideration of cost of care. Then we have the issue about the quality of care, which means that how well or how good is the care itself. And this has got, again, like the health system performance, three individual entities. The first entity is the entity of structure, which means that what facilities are present and how are they working. The second entity is the process of care. That tells us as to, what are the steps through which a person has to go through and how good are the care processes that are taking place in the community or in the country. So how well do the health systems are working, how well they're evidence-based, or what else is going on. And then we talk about, after all of these structures and processes, what are the outcomes that we are seeing as a result of all of these input parameters. So these things will decide the quality of care for us. So let's go and talk a little bit about the structure of care. Now, when we say structure of care, the first consideration is, where is care provided? Is it provided in the home setting? Is it provided in the community? Is it provided in the hospital? Is it provided in the clinic and outcomes setting? These are all things that we need to consider in terms of where the structure of care is provided. And you will see that we need to worry about the quality of care in order to understand access to care, because all of these things will have its own direct bearings on how people are going to avail or access care in their own ways. How are people going to reach care? For example, it's easier if the care is moved to home. It's quite difficult if the hospital is located far away. So those are some of the considerations. And in them, things like, are even those structures are present? And if they're present, are they sufficient? Are they meeting the needs of people who are going to use those services? What is the nature of the health workforce? Are there enough trained people in the health system that you're trying to understand? And that is a very important consideration. In terms of the process of care, we generally talk in terms of the evidence base of the care. So is the care that we are talking about, does it have an evidence base on which it is based? I mean, is there good evidence? Is that based on studies that people have done? Yeah, are this based on best practices? More importantly, are right people delivering the most appropriate care in the right time? So if you may have heard about that proverb called "a nick in time saves nine." So, are things working properly in the right and appropriate time? So again, in terms of understanding the access of care, whether care processes are happening in proper time, the right people are doing it, makes a lot of sense. We'll see in a bit. Finally, outcomes of care is also very important. So what happens as a result of all of these inputs of the care processes? So you input the care processes to individuals and to members of the public, and then at that point, we can expect one of the three outcomes: that a person or a group of people will completely recover and they will have good health-related quality of life, HRQOL. Or people make partial recovery and there is not an entirely excellent health-related quality of life, but a partial recovery is in which they're functional. At least they can participate in their day-to-day life well. And finally, a care process can leave some people with disabled, and some people will die as a result of this. So these will contribute to the burden of disease. So quality of care is also very important in order to understand the health system's performance, and quality of care and cost of care together contribute towards the access of care. Because if the cost of care is very high, people may not be availing of the services that are made available, or people may not be utilizing the services that are still present. If the quality of care is not very good, then people who can pay for those cares, who can afford care, will look elsewhere. So access to care is an intimate issue. In order to understand access to care, you do need to understand that care has got a cost to it, and care has got a quality issue to it, both of which must be considered simultaneously. So what does access to care mean? Essentially, you can think that access to care means the extent to which people can avail of the healthcare facilities in the system. I say country, but it can be community. It can be your own little village or town or neighborhood. But it is more than that. Access to care is also an ability of people to seek care. So if you are you capable of visiting the care center? So for example, there is a health center in the campus for those of you, for the students and also for the faculty members. Are people able to make to that health center in time? If you've got a class and you've got an appointment, then there is a conflict, you're not able to reach that place in time. But access to care is also can also be visualized, or can also be thought in terms of a right to care. Very often we say, and it is a common thing to say that health is a right. But when we say that health is a right, what we essentially mean that I have a right to health care. And when I say that I have a right to health care, what I mean is this, that I have a right to access the right kind of health services offered to me. And this concept of access to care is dependent on both what is being provided and what is being demanded. So if you do not know what you need, then there is an access to care issue that you're not making good use of. And if the services are not even provided, then access to care will not even take place. So those are some of the considerations that are very important when you talk in terms of access to care. What are the different types in which we access care? So which means that the care process is present in the community. Are people accessing it? Or is it made available at all in the first place? If the care process is made available, regardless of whether people are using them, then that kind of an access is called a potential access. Say, for example, there are vaccination facilities that are being set up, but people are not making use of it. They're going somewhere else. So even though the access is a potential access, people may or may not be using it. Then there is a thing called realized access, which is essentially what is utilization of care talks about. So, if the vaccination center is set up, people are walking into the vaccination center, they are getting themselves vaccinated, that access is called a realized access. Then there are two other issues that are very important: unequal access and inequitable access. We are going to focus on inequitable access a little bit in details. Equality of access tells us that all of these care facilities are made available equally to everyone. But that does not mean that everyone will be able to make use of those facilities as well as everyone else. And this is where inequity of access becomes a problem. For example, think of a situation where heart surgery is being offered at a hospital in your neighborhood. Now, you would normally think that a person who is elderly, frail, and a person who has got a biological need will be prioritized to get the surgical surgery. However, if it turns out that a person who has got more money and can pay for those services is prioritized before a person who is actually in need of that, then both people can access the services, or one person can and the other person cannot. But in this case, the access is determined not by the person's biological needs, but by the person's affordability. And that kind of an access is called inequitable access. So again, some people can pay for private surgery and can get faster treatment, and some others will have to wait a long time. If that is done on the basis of not a biological reason or a physiological reason, but it is done only on the basis of, say, for example, somebody's affordability, ability to pay, socioeconomic status, then that kind of an access is an inequitable access. The next slide will show you a little bit in details as to what that means. So think of it like the difference between resources that are made available, as you can see on the left-hand side panel. So equal resources are made available to everyone, but it does not mean that everyone can make good use of those assets that are made available. So these people all can stand on the pedestals, but they cannot all watch the game. On the other hand, equity tells us, which is on the right-hand side panel, is this, that the resources are made in such a way that people who are weaker, people who deserve to see or deserve a certain kind of facility, are given more resources so that they can make good use of that. So what we are trying to do here is to make an argument that an equitable access is better than an access that gives a stress on equality. So it's not just enough to make the assets or the healthcare services provision all over the country equally, but it is also important to see that certain groups of people who will need them will they are made available preferentially to those people. So that is an issue that directly relates to access to care, and we are going to take a look at it right away. So what does explain access to care? The most popular model, at least up till the 2010s, was this model called the Anderson model of access to care. It is also referred to as a behavioral model of access to care. Central to this model is this little square box, or this little rectangular field that contains the three words: predisposing, enabling, and need-based care services. So this in turn holds the other ones. So healthcare system and external environment contribute towards the behavioral aspects of predisposing, enabling, and need variables. These in turn lead to specific health behaviors, such as personal health practices, whether a person individually would like to go and get themselves, say for example, vaccinated, or whether they will go and travel to the vaccination center, the use of health services, and in turn this will lead to the perceived health status. So a person may think that I am well, so this is called self-reported health, or evaluated health status, which means a person can say that, okay, a doctor or a nurse or another healthcare provider will decide whether that person has got a good enough health status, and whether that person will need some additional access issue or not. And also very important to this framing of the models is consumer satisfaction. If a person is happy with the health service as it exists in the system, then that person is more likely to access the services in future. So that's something that's also very important that we need to understand as we start talking about it. So the predisposing, reinforcing, and need variables are very important. So what are predisposing variables? For example, demographic variables: age, gender, perception of the illness, whether a person feels that that person would really like to go and get to the place of care. Enabling factors. Enabling factors are the ones that are made available to you by your health services system. So for example, the structure of care that we were talking about in the quality of care bit, presence of the hospitals, the number of, doctors versus patients ratio, availability of transportation that a person has to take care of. Is there a parking lot? Is there a bus stop closest to the hospital, and so on and so forth. Then there's a need. Does a person feel that he needs to go and make care available, or is the need evaluated by a professional? So all of these things are very important in order to understand how access to care will take place. So that is one of the models. That is the model of Anderson's model, and various studies that were conducted on Anderson's model eventually came up with the conclusion that need is a very important factor how people would access health services. So if people feel the need, then they go and access health services. If the specialists or if the clinicians determine the need that a person is going to go and do access health services, then they will do that. So need is kind of a proximal driver why a person is going to access health services. But in addition to that, there are now newer models that have emerged. One of them is the 5 A's model that talks about the approachability of the health services. Is the health services being taken to you? For example, mobile clinics, or if the health service can be so friendly and so approachable that people feel comfortable to go and use them. Is the health services acceptable to people? So if your care process, if your traditional care process is your way of the world, is your view of the world is in conflict with what is being imposed on you, then many people will not accept that care and may not go to that provider, but go to other people. So for example, Chinese care medicine or alternative care and things like that. The care process is acceptable to people. Are the care processes available? That's where we're talking about the presence of the hospitals or the care facilities or other things that are in the community. Can people afford to pay for this care? In other words, are they so expensive in terms of time and money that people cannot even pay for it? Is the care appropriate? And this is where the care processes are quite important to understand. And this in turn drive the healthcare needs, the perceptions of the needs and desire for care, the ones that we're talking about in the Anderson model, healthcare seeking behavior, and then reaching the healthcare and healthcare utilization. So are people reaching the are people reaching the primary care process, the primary access, or is another person influencing them to reach the healthcare services, secondary access to the care? So there is via media. And so what are the consequences, which we also call as outcome, other economic outcomes? What are the satisfaction with the care process, and what happens to the health status? And therefore, there are these 5 dimensions of this care. Yeah, the ability to perceive is the approachability of the care, the acceptability of the care, the availability of the care and how care can accommodate the people who need them, whether people can afford care, and whether the care is appropriate. So these are the 5 dimensions of care, or in other words, 5 dimensions of access to care services that are already available to you or us, to the general members of the public. So care should be approachable, care should be acceptable, care should be available, and people will be able to afford them, and care must be appropriate in terms of meeting the needs of the people. So that said, we need to understand what is it going on in New Zealand at the moment. So let's spend some time trying to take a look at these things. Now, there are a couple of resources which I hope that you will make use of. One is a very nice Tableau dashboard that the New Zealand Ministry of Health has made available to anyone who wants to study them. And the second thing is a Shiny apps that you can use. So if you click on these 2 links, they will take you to specific health related web pages where you can explore these resources and you can make good sense and good use of them using them. So let's take a look at some of these variables one by one. The first one that we're going to take a look at is how people are accessing GP services, total all populations, and for individual ethnic groups and deprivation levels. So we start with the first one. Here we are looking at access to care by access to GP care for all New Zealand population, and we have stratified them by age and sex. So the population group is age group from 15 years and above till 75 years and above. The left hand column of the numbers is about the total number of people who are accessing care. The middle column is that for males, and the right hand side column is that for females. We are only going to focus on the total number of, or total percentage of people who are accessing, who were able to access GP care in the year 2021. And you can see that overall 73.9% of people were able to access care. And if you take a look at the age group, you can see that age group, particularly for the working age group, it was quite high. The highest were the elderly age group, 75 years and above. The lowest were younger age group, 15 to 24 year age groups, and 25 to 34 year age group. They did not access the GP care as they would, as the older people would. So that speaks to you how demographic factors are important and which age groups are more likely to access GP care when that is made available to them. But when it comes to ethnicity, you can see that there are certain things quite interesting, that the European population were accessing healthcare more than the Maori population. Women were accessing healthcare more than men. And European women had the maximum access to GP care compared with Maori male. So Maori males had least extent of access to GP care. European women had most access to GP care. So that tells you that there is an ethnic difference that is worth considering. And why is this so? And so those are some of the things, that are the questions that we will be asking. And these are the questions that you will be asking and investigating, and see what information you can find more from these things. This becomes quite interesting when we start looking into the deprivation levels across the country. So the country is divided economically into 5 percentiles. So quintile 1 is the least, rich or least, resourceful or kind of least deprived. Okay, let's say quintile 1 is the least deprived and quintile 5 is the most deprived. So quintile basically means quintile 1 is the bottom 20%, quintile 5 is the top 20% in terms of their household income and resources. And you can see that the most deprived people, okay, so quintile 5 is the most deprived people or people who are really, really poor. These people are accessing the services much lower, at least 5% percentage point lower than people who are least deprived or in the top 20% of their income and resource bracket. And this becomes remarkable when you start looking into men and women statistics. We have seen that women tend to approach health services and access health services more than men, and you can see that the highest categories are in quintile 3 amongst the women, and it's actually very low amongst and you can see that interestingly among the men who are relatively richer, they don't tend to access health services as much as women, but you can see that really low levels of health services are being accessed, at least by way of GP care, by people who are most deprived or the poorest sections, people who have got very least resource. The other sets of statistics are very similar when this one's the tables, is the ones that people have got unmet health needs. Again, stratified by age and gender, total men, women in the 3 columns, and overall we see that about 27 or about 28% of New Zealand population have unmet needs, unmet healthcare needs. And here again you can see that the population that has got least unmet healthcare needs are 75 years and plus age group because of a number of reasons. So you can see that the elderly aged care has got much lower unmet healthcare needs than the other age groups. And you can see that the working age population, that is 25 to 54 year age group population, they have a significantly higher unmet healthcare needs. And unmet healthcare needs are higher for women than for men. Men have got much lower than the national average. Women have got much higher than national average. It's also very high amongst the working age women, unmet healthcare needs, when we start talking about the entire country. If you start talking in terms of the ethnic group, you can see that the unmet healthcare needs are very high for the Maori women population. It is not too bad for Maori male though, and for the entire population, for the Maori population, you can see that their unmet healthcare needs are much higher than the other ethnic groups. The unmet healthcare needs are lowest amongst the Asians, and you can see that the unmet healthcare needs are least experienced or as reported in the New Zealand Health Survey, least by the Asian men, but quite high amongst the Maori women, and also to some extent among the Pacific Islander women, and it's also very high amongst the European women as well. So if in summary, what we are seeing from these data sets, the other thing is this, that if you take a look at the neighborhood deprivation, you can see that the results are not unsurprising. The poorer people are, the more that they're likely to experience unmet needs. So these kind of tell us a story. And that story is this, that as people age, they have got higher levels of primary care access. They also have less likelihood of unmet healthcare needs. The Maori and Pacific Islander people have got lower levels of access to primary care than Europeans and Asians. And people who live in more deprived neighborhoods have got lower levels of access or unmet needs than those who live in less deprived or upscale neighborhoods. So in totality, these things suggest that there is a level of inequity of access to care in New Zealand. So although healthcare services are made available across the board. Not everyone is accessing them equally. And that's an important takeaway lesson from this exercise. So in summary, we have learned today that health services performance is determined by cost of care, quality of care, and access to care. So access to care is a cog in the machine of health services overall performance, and you should be viewing them as such. Access to care is synonymous with people's capacity to reach the care available. If that's not, if that is not possible, then there is no access to care. Access to care has got several determinants, two important theories: predisposing, enabling, and need variables, as was defined and designed and discussed by Anderson's model. And then there is this 5 A's model, the most important them, including appropriateness of care. So predisposing variables, enabling variables, need variables, and appropriateness of care are some of the major factors that determine the access to care. Need for care is a very important determinant. And we have found through some preliminary investigations that in New Zealand we have serious issues with respect to inequity of access, particularly for Maori and Pacific Islanders and those who live in more deprived areas. So this is an important issue, and I think with these thoughts I leave you with it. Thank you very much for listening.